The World at One. This is Sean Lay with 45 minutes of news and comment. NHS England is working on plans to close or merge dozens of services in order to ease its financial crisis. Is it time to consider making patients pay for services? We'll hear from the Conservative Health Select Committee Chair and Labour's Diane Abbott. That's all after the BBC News, read this lunchtime by Alan Smith.
Labour has said proposals to make significant cuts to healthcare services across England are a damning indictment of what it called the government's underfunding and mismanagement of the NHS. More than 40 areas have been asked to make efficiency savings, which could include a reduction in bed numbers, the closure of district hospitals and changes to GP services. NHS England said it was essential to identify services which were unsustainable and insisted that no measures would be implemented without consultation. Here's our health correspondent Jane Draper.
Labour says these proposals amount to a crisis. The plans are being drawn up for 44 different parts of England because the health service needs to save £22 billion by the end of this decade. There's concern that many people are unaware of proposals for their area. Some include potentially dramatic changes, such as reducing A&E services in the Black Country and closing a hospital in Leicestershire. The Department of Health insisted no local plans had been approved or signed off yet, and it said there'd be rigorous consultation as well as central scrutiny. A coalition of health charities called National Voices said the current system was struggling to meet patients' needs, but it said changes shouldn't be made behind closed doors.
Have we reached a watershed moment for the health service? Yesterday, the head of NHS providers, an organisation representing hospitals, said the sums simply don't add up any longer. Unless the taxpayer is prepared to put in more money, he said it might be necessary to discuss a different way of funding it. One model frequently mentioned is co-payment. Richard Murray, Policy Director at the King's Fund, the health policy think tank, is on the line. Richard, welcome to the programme. What exactly do we mean when we talk about co-payment?
Co-payments mean that, for example, if we apply them to the NHS, that the NHS is still willing to make a contribution to the cost of treatment, but it's not willing to pay all the cost of treatment. And the main example you see in the NHS at the moment for many people is prescription charging.
And those prescription charges, they've gone up over obviously many years, but I mean they date back to the 1950s when the then Labour government said actually we can't make the sums up unless we start charging people for prescriptions. That's
exactly right. There are other areas that the NHS will charge in. Dentistry and optical care, probably the two other key examples. But even with prescription charging, you have to remember that the number of exemptions in the NHS are very, very broad. So no old people have to pay prescription charges, pregnant women don't pay them. And so though the charges are fairly high, only a small minority of prescriptions actually get issued with a charge.
How are individual health trusts handling this issue? I mean, are there trusts who are actually already extending the areas in which charges are being made to patients? Because there's been a lot of debate about things like, should people be charged if they miss GP appointments? Should they be charged for making GP appointments? Should they pay themselves for things like paracetamol? Indeed, for example, some of the special foodstuffs that people have needed in the past that are now available relatively cheaply on the high street, that sort of thing.
Indeed, but in general, it's not the decision for trusts or for GPs about who or what gets charged. It's a power reserved to government. So individual hospitals, individual GP practices can't just decide whether or not they charge. In some areas they have to, in other areas that they can't. They have to look at other things. They can choose around things like car parking on the margins of the NHS. They can also choose sometimes about waiting times and sometimes just to try and stretch staff ever more thinly over the number of patients that they've got.
So there are lots of different ways you can make the money go further. But in the end, you think that those are, if you like, at the margins of the costs that the NHS faces, and that perhaps we need to look at this a bit more fundamentally.
I agree. And remember, some of the things that you can do at local level, like stretching staff over more patients, isn't necessarily a good thing to do. You can see a lot of people living in the community at the moment dependent on services like district nursing who are getting fewer visits, shorter visits. This is probably not good for them, and it's almost certainly not good for the NHS either.
There we go, Richard Murray from the King's Fund. Thanks very much. Well, the question becomes particularly appropriate at the moment because across England, the NHS has been asked to come up with what are called sustainability and transformation plans. Since these will include the closure of some departments and even entire hospitals, some will see the title as a euphemism for cuts. In and around Leicester, it's proposed to reduce 3 acute hospitals to 2. In the Black Country, the draft plan suggests 1 district general hospital should be closed altogether. In West London, the plan involves reducing the number of face-to-face consultations between patients and GPs. Well, the Conservative MP, Sarah Wollaston, chairs the Health Select Committee. Dr Wollaston, good afternoon.
Good afternoon.
Is it fundamentally a question of having not enough money or too much demand? And which is going to be easier in the long term for us to manage, do you think?
Well, I think it's both, and we certainly need to do far more on prevention, for example, to help reduce the demand, and there's a lot that could be done around that. But fundamentally, we've seen the NHS facing the longest period of financial squeeze that it's seen in its history. I mean, we've seen 6 years as the last period. We've seen 1.1% annual increases, but we know that the rate of inflation in terms of the demand in the health service is far greater. So you're opening up a gap between the two. And so therefore you need to look at how you can actually change the way that people use health services to try and manage that in a better way. Putting more money, for example, into primary care, we know, is a good way of helping to take costs out of the hospital sector. But there are also things we need to look at as well around the impact of cuts, for example, to social care, because what we've seen in the figures released this week is confirmation of increasingly how difficult it is for patients to be discharged from very expensive hospitals back into the community. So we need to look at the whole spectrum of this, from prevention, from how we manage demand, where people actually see doctors, rather than seeing them in their primary care setting rather than in casualties, and also how we make it easier for people to get out of hospital and be closer to home, not only because that is less expensive care, but mostly because it's a better setting, to be in the community than in a hospital bed if you don't need to be there.
The difficulty, I suppose, is that a lot of these changes will cost money in the short term and may not actually save a great deal of money in the long term, because you're managing the demand but you're not actually eliminating it or ending it. People will still need to be treated somewhere. They still need to be treated. You might get them to travel a bit further to a different hospital, but you've still got to pay for that treatment.
But ideally you could prevent the need for them to be there in the first place, or treat them in a better setting, a more appropriate setting, which is often also less expensive. But if you go back to that point you made earlier about these sustainability and transformation funds, the trouble is that the money that was put in to this so-called sustainability and transformation programme is mostly being sucked into plugging the debt, the provider deficits, and relatively very, very small amount of it is left for the so-called transformation. That's to say, investing in the new premises in the community that allow you to make those changes. Sorry.
No, sorry to interrupt you, but just on the question of funding, I mean, we spend as a proportion of GDP less than countries like France and Germany. We obviously have a different health system. Theirs is a public system, but it's also partly funded by health insurance. Do you think we need to look down that route? Is co-payment enough, or do we need to go further?
Well, if you look at what the Commonwealth Fund judgment was on the way we collect money for the health service, they decided that we ranked first out of 11 systems in efficiency, because we have a very efficient way of actually using health service resources. We also have a very fair way of distributing it. And I think that the trouble with these co-payments and top-ups is that they make a system less fair. They're also very expensive to administer, and they don't raise as much as people think they will because of the number of exemptions. So I think for a number of reasons I wouldn't support going down that route, and nor would I support going down an insurance-based model, simply because the scale of the upheaval that would involve, and as I say, the judgment internationally is that ours is the most efficient and fair way of collecting money to fund the health service. So I think we should stick with a fundamentally one that comes out of tax, and there are other suggestions around using national insurance more to collect the money. But I do think that there's a very strong case for saying that the health service now needs more money, but also social care, because we know that there's a huge impact on the health service because of the restrictions in funding and the cuts to social care.
Sarah Wollaston, Chair of the Health Select Committee, thanks very much. Diane Abbott is Labour's Shadow Health Secretary. She's with me. Welcome, Diane Abbott. Do you think we are at a crisis point, or is this simply a question of kind of keep mucking on and keep making the best of it? Because fundamentally we have a system and we still value that system.
Well, I mean, the NHS is facing its biggest financial crisis ever, and if things carry on like this, there'll be a huge deficit by 2020.
So what would you do about it?
Well, the Labour Party is completely opposed to charging, and we think
Well, we charge already, don't we? I mean, as we say, prescription charges, car parking charges,
yeah, but sure,
dental optics, all the rest of it, we've been charging since the 1950s.
We are completely opposed to ordinary people going to their GP and being charged. We are completely opposed to charging, and we think, actually, that an insurance-based system or co-payments is not cost-effective. First and foremost, we think there is money to be saved. Every year for the coming decade, we're going to be spending nearly £2 billion on PFI. And I've spoken to CEOs of big London teaching hospitals who are talking about buying out their private financial initiative arrangements because it would be so much cheaper at current levels of interest.
So to do that, would they have to actually be able to borrow money from elsewhere, or the Treasury pay for it? I mean, there would have to be money supplied to do that.
The CEOs I'm speaking to are talking about borrowing money as an institution. The other issue is we're spending £3.6 billion on agency staff. There's no need for the health services to be spending all that money on agency staff. And then there's the question of drugs. Some of these proprietary branded drugs, there's a markup of times 73. So we think there's money to be saved. And I think in the long term, we do need to look at public health. We do need to look at prevention. 10% of the NHS drugs bill goes on drugs for diabetes. We think public health issues like diabetes, like obesity and exercise and alcohol could, in the long run, bring down costs for the NHS as a whole.
You wrote an article last month for the Morning Star newspaper in which you set out some of your concerns about the health service, but you also said that fundamentally Labour will oppose, as you put it, all damaging cuts. Are there any cuts that you would see as not damaging and therefore ones that you could support?
I can't think of any, because the cuts we've seen and the cuts that are proposed in these new plans that we're reading about today will actually be damaging. This idea, for instance, that you're going to cut the amount of patients that actually see a GP face-to-face and get them to do it online or coach them to manage themselves. We already have some of the poorest cancer detection rates in Europe. A quarter of people with cancer will die within 6 months because of late detection. How much later will detection come if the only way you can speak to your GP is online?
On the basis of that, then, your only option is left, presumably, is to say we actually need to spend more on the NHS as a proportion of GDP. Is that fair?
We certainly aspire to maintain what we spend on the NHS as a proportion of GDP. And as I say, we think...
we spend less than comparable countries.
I know.
Given what you described as the pressures, given that closing the gap in demand is proving so difficult, given the deficits that trusts are dealing with, that is the only solution. So you've ruled out all the others. You've said you don't want any increase in co-payment. You said you don't want to change the system of funding. So you've got to spend more, haven't you?
You've also got to save money. And I've explained to you, 3.6 billion on agency staff. Well, you're talking about billions of pounds. PFI, agency staff, the drugs bill. There's money to be saved there before we go into these ill-thought-out cuts. That's my view.
We did ask to speak to the Health Secretary, a Health Minister, or indeed anyone from NHS England. No one was available. Instead, the Department of Health offered a statement to be read out. It says plans are being developed in each part of England to encourage more collaboration. Changes to local services will only go forward where they're designed by doctors and in the clear interests of local patients. That's what the statement to us from the Department of Health says.